I'm so happy to see this conference move from a club that we started this whole a few years ago to the biggest daddy of them all, the Geo Center. So that's the happiness I have when I see Manoj and Purvi succeed so much. And I have made a little change because I really think that we have still not understood the concept of heart failure and diabetes very well. So I am dumbing this down for my own understanding. These are my conflicts of interest. So let us take this patient. A 58-year-old woman has type 2 diabetes for 10 years. She has hypertension and dyslipidemia. She's on a sulfonylurea, metformin, a glitazone, a gliptin, everything else. Her blood pressure is 145 by 95. A1C is 8.1. EGFR is 60. Urine microalbumin is 200. And a FIB4, please calculate it in your patients, is 1.65. I do coronary artery calcium scores very regularly. It's 150 in this patient. She does not have shortness of breath other than in climbing an extra flight of stairs. So how many of you think that this patient has heart failure? One person. So Joy, you don't count. Presidents only have casting votes. Chairpersons don't count. But it's interesting because if I ask this question to anyone, they will say, I don't think she has heart failure, right? That is the truth. So the first question is she at risk for heart failure? So let's look at this very carefully. Over a period of time, what has happened is, you will notice that myocardial infarction has moved down this list of presentation of cardiovascular illness and diabetes. And largely because of people like us, we have been using statins for many, many years that has brought down this risk. So a silent epidemic of heart failure has moved up this chain. So this is one bit. So heart failure is not discovered by the SGLT2 inhibitors. There have been studies much before that. There's an increased risk of heart failure, including the Framingham heart study. I'm not going to show it today for this thing, but this is something important to understand. The second thing is that in India, it is very much a young person disease, just like diabetes. It has a high 1-year mortality, despite having a younger cohort than the West. The fantastic data that comes from the Indian Heart Registry. And this, of course, we've heard over a period of time that this is no diabetes. This is diabetes with HFpEF and HF. The HFpEF hospitalization rate for diabetes is the same as a HFrEF hospitalization in patients without diabetes. So clearly, diabetes and heart failure isn't very interlinked. This is almost like the 1999 data that you have, right? So definitely she's at risk for heart failure just by being a diabetic. Now, what are the factors? First is BMI. This is something that is very obvious. You're obese, you're at risk of heart failure. Hypertension, which Anuj spoke about so beautifully today, and I think it's a call for action. It's there. A 12% increase in heart failure, every 10 millimeters increase in systolic blood pressure. Dyslipidemia, and remember, heart failure and DKD go hand to hand. Just like you think of eye disease, whenever you see renal disease, think about heart failure. This is a point that I want to spend half a minute on. Heart and women, they wear their heart on their sleeves, but they also have great problems with heart disease, right? The heart failure risk in women is 5-fold higher than non-diabetics. This is something that you want to remember. And I want to talk to you about the ARNI recommendations in women. Second, there are higher hospitalization rates in women. Third, women are less likely to get cardioprotective drugs. This is something that is very well known from past. So remember this part. And of course, there is a link between A1C and heart failure. So quickly to reconcile, is she at risk? Absolutely. Remember also that there are multiple things that we want to think about when you think about heart failure. One is, remember, it's a clinical syndrome. But now we have stages of heart failure depending on the risk. So any diabetic is automatically at stage A. Are they moving to pre-heart failure, which is stage B, which is stage C is heart failure or advanced? I won't talk about C and D simply because I'm not qualified to do that. Then there's a classification based on the ejection fraction. HFrEF, HFpEF, now HFmrEF, all the other stuff that we have. But the idea is for me to sensitize you, and I'm not going to get into all the details. So this is how we have. So if you go back to this woman, type 2 diabetes for 10 years, hypertension, dyslipidemia, blood pressure, BMI, A1C, DKD, presence of coexisting atherosclerotic cardiovascular disease, each of those tells you that this person is at risk for heart failure. But the question is, how do you test this person? What should you get? Well, what should you get this person? Next step in this patient. If you agree that she's at risk for heart failure and may have underlying heart failure, what test will you get? How many will get a 2D echo on this patient? Okay. Now, I want somebody to tell me how many people think that the 2D echo that you get will help you detect subtle heart failure. Exactly. And between Sujoy and me, Sujoy works at one of the premier institutions in this country, and I work in a dinky hospital called Apollo Hospitals, Chennai. And I can tell you, to try to get our technician to write EE prime has taken me 4 years. This despite being the largest cardiovascular institution in the country with the greatest number of angioplasties and at least 10 interventional cardiologists at hand, waiting to put that catheter inside you. To get EE prime reported on every echo took me 2 years. Now, I'm not even going to try to measure global longitudinal strain, which is the gold standard. So, I don't get echoes on everybody anymore. Instead, what do you think I get? NT-proBNP. The simplest, and don't tell me cost, because today, whether you are in rural Midnapur or in Mysore, some lab will transport it to another place, and the more you order, the less it becomes expensive. So, many of the guidelines now talk about an NT-proBNP greater than 125 as increasing the risk for heart failure and diabetes. Fantastic marker. Remember, over the age of 60, use a higher cutoff, which is like 200. But otherwise, an NT-proBNP, the incident heart failure risk is 5.2, and the heart failure hospitalization and death is 3.52. I have a risk score which I have developed, which we use in our EHR, that helps us understand the flow of heart failure, and that also tells you what is the impact based on things. So, start using these tools. Your EHR should really be incorporating these kind of things. I'm not trying to sell mine, but I'm trying to tell you, start using predictive scoring. So, from stage A, it moves to stage B if you use a biomarker. And this is our study, just a cross-sectional study that looked at patients, and what you'll find is that the average NT-proBNP in a community clinic, the average is around 153, and you'll find as the number of years increase, the NT-proBNP actually increases. So by 10 years of diabetes, the NT-proBNP levels are 225. A follow-up study is in the way, but I'm just telling you this was just published last year in Diabetes Care. So this patient had an NT-proBNP done, it's 300. So clearly, this is when you get an echo and you tell them, I want you to measure subtle things like EE prime. Don't just tell me diastolic dysfunction. So you really have HFpEF versus HFrEF. I don't have time to tell you which is what. There are two different pathophysiologic mechanisms. Both have different outcomes, but it's important to understand that it's not, HFpEF does not always lead to HFrEF. But look at this, something very interesting in this part. The reason why you want to get additional things than just ejection fraction is the diagnosis of HFpEF is largely also made by the presence of an E prime. So an E prime between 8 and 15 and a BNP more than 200 already makes this patient HFpEF. Remember that. So it's a little complex, but remember that the NT-proBNP is a very, very good marker. And lastly, remember for women, the LVMI needs can be much lower and still have heart failure. I'll show you the women differences in a moment. So here's this patient, 300, 2D echo shows an E prime of 15, ejection fraction of less than 60. Now let me show you something very interesting after this. First thing is, in women, there is a greater attributable risk from traditional risk factors. It's something that we want to understand. Second, there are unique sex-specific risk factors that include this. Lastly, there is a distinct symptom profile. More dyspnea, greater, worse health status. For example, this woman, all she would have done is, she would have just lowered her exercise level to reduce the symptoms that she has, right? Lastly, there is more concentric modeling, more impaired diastolic relaxation. Therefore, sex-neutral ejection fraction thresholds are underestimating LV dysfunction. And we really need more data on this particular area. But remember, women suffer this impact a lot more than men do. Right. What is the first thing you need to do to get the heart failure risk down? Treat the glucose well. A 16% decrease in A1, 1% reduction in A1C reduces the risk of heart failure by 16%. So take care of the diabetes well. Second, what should be avoided? Very controversial, but I'm going to tell you anyway. The moment you get to stage B, the recommendation is avoid these three classes of drugs: thiazolidinedione, sulfonylureas, and DPP-4 inhibitors. So a little interesting because now thiazolidinediones, you really don't want to stop it till class C because they have benefits at this point of time, MASLD. But the data seems to be that sulfonylureas, we keep talking about sulfonylureas and other things, but nobody looks at it in heart failure where there's an actual increase. And for heart failure, there's no distinction between the older and the newer sulfonylureas. For CVD risk, there is a difference: ischemic deconditioning, myocardial infarction. But for heart failure, it seems to be neutral. Second, irrespective of all these studies, the FDA advisory on DPP-4 inhibitors still stands, right? I won't get into the details. Saxa is different, the TCOS is different, LINA is different, but FDA has still given you a blanket advisory. It has still not taken away saying this is better or that. But I have a feeling when you combine with an SGLT2 inhibitor, the risk goes down, and therefore when you combine it with an SGLT2 inhibitor, it's probably not an issue. Glitazones, clearly there's an increased risk of heart failure, we know that, right? Then, what should be done? The four pillars of action for heart failure are SGLT2, RNE, beta blockers, and MRA. Most of the time, by the time a beta blocker is required and the others are required, you probably need a cardiologist to take care of. I'm too low in that pecking order to understand that part of the story. But let me talk to you about this part of the story, which is where I and most of us are. Today, the number one drug for prevention of heart failure in diabetes or no diabetes is an SGLT2 inhibitor. We have data across the spectrum. This is empagliflozin, EMPA-HEART in acute failure, recent worsening, sotagliflozin and recent worsening of heart failure, the DELIVER in chronic stable, which is DELIVER with DAPA, DAPA-HF, the EMPEROR reduced, and then in the preserved heart failure, you have EMPEROR preserved, you have preserved HF, you have CHIEF HF, all of these showing one across the spectrum of heart failure, SGLT2 inhibitors. And you don't have to wait for long, start immediately. Before we used to talk about slow progression of GTMD, guideline type over a year to add medications. No. You already want to get in one and maybe the second very quickly. So we understand that almost all diabetics who are at risk for heart failure or who have established indices of heart failure require an SGLT2 inhibitor. There's no doubt about it. But should you add a second drug? And that is a big question. And I won't get into the data. This is a slide that I use, especially for HFrEF, because it makes me understand many things. HFrEF, a little beyond my pay grade, I won't spend time on it. If you have HFrEF, if you have fluid retention, and class 2 to class 4, a diuretic is required. Right? Those who can't take any of these drugs, an ARB. But look at the data on ARNI. For women with any ejection fraction and HFrEF. Remember I said we are underestimating cardiovascular function in women. The recommendation is start an ARNI. If it's less than 60 like this woman, you really need to be taking that ARB off and getting the ARNI in. For women of all ejection fractions and those with fluid retention and MRA. So clearly the data seems to be shifting towards adding an ARNI in HFrEF fairly early. So at least at our level, the primary and the diabetes care level, SGLT2 inhibitors, and in a patient like this where there is evidence of HFrEF, starting an ARNI. And then the next level, I think, belongs to a cardiologist. So this is the paradigm study, which is looking at sacubitril valsartan. The paradigm HF showed a 20% reduction in primary endpoint, 21 degrees in heart failure, decrease in NT-proBNP that comes on fairly well, ejection fraction improving. This is an HFrEF study. The Pioneer HF study also showing greater NT-proBNP decrease in sacubitril valsartan. So clearly, the addition of sacubitril valsartan with an SGLT2 inhibitor is something that's recommended as a second pillar of therapy in HFrEF. The third and fourth pillars I'm not going to talk about. It's way beyond my pay grade. But I think the idea of this talk was to help you understand that heart failure exists, that diabetics are at risks. We need to measure it using a biomarker, follow it with an echo. Most patients will qualify for an SGLT2 inhibitor. Well, everybody qualifies for an SGLT2 inhibitor because it should be in a tap water, but at least these patients do. And then maybe ARNI in most of these patients. So in this particular patient, reworked, the cardiology opinion was obtained, lifestyle changes were changed, SUTZD and DP4 inhibitors were discontinued, started on dapagliflozin, basal insulin, you could use a GLP-1RA again, the data on it. Then ARNI was started, ARB was discontinued, statin was continued. So I do primary care diabetology, and I think most of us do that. For that, I thought I will illustrate a simple patient without too many studies, too many HRs and RRs, so that we understand this a little better. So how many of you will get an NT-proBNP after this talk? The rest slept. Thank you so much.